Hi, Doug Dormer here, and this is my series, Consumer Health Informatics, Empowering the Patient as a Consumer. And in this lesson, Module 2, Lesson 2, I want to focus on legislation and regulation from 2000 to 2016. Now, I have to tell you right off the bat, I mentioned in Lesson 1, this isn't about legislation specifically for consumer health informatics. There's been a real dearth of that notion. What it's about is the history of health information technology, which takes us to where we are today with respect to consumer health informatics. And I have to say, as I look back on my own career over the last 30 years, I've really been at a front row seat, not only to consumer health informatics, but to health informatics in general. And so I will tell you my experience to the extent that I think it contributes to your larger understanding of what's going on in the industry. Well, I don't know if you have this experience. I gave a lecture in 2017 to students in a master's program. And I stood up on the board and I just drew this. I kind of had an idea of what I wanted to do. And I just drew it on the board as I was doing the lecture. And I thought, wow, that's pretty good. I'll have to take a picture of it so I can come back and make it into something presentable with technology. Well, here it is, early 2025, and I've got the same image. That speaks to my ability to, both my ability to draw as an artist, a graphic presentation here, but also to my ability to, or willingness to invest in how do I do this through technology to make it look prettier. So, such as it is, it serves the purpose, I think. Let's find out. I begin with 2004, which is kind of the old world. In my mind, anything 2004 and before is before the government really began to think about electronic health records. And if you're old enough, you'll remember that during that time, you go into the doctor's office and they had like rows of 7-foot high stacks with file folders, and your information was one little bucket across these many different stacks of information, all in paper. That was the world pre about 2000, except with one exception. Even in the 1990s, and I don't know if it goes back into the 1980s, but certainly by the 1990s, there was a significant advance in electronic systems, electronic information systems for healthcare that have evolved into what we call electronic health records or electronic medical records. But the purpose for those systems was to maximize revenue for those hospitals, for those providers. And the way they did that was by capturing information about the services that their staff provided, because they found that in the absence of an electronic system that acted as a check, as a monitor, to make sure that you captured the information about what you did, they were losing lots of money. You were providing services for which they weren't getting compensated. So that was the original motivation of companies like Epic, the huge, the gigantic, the largest health information technology vendor in the world today. It started in that 1990s or earlier, I don't know, period, as a revenue maximizing solution. Now, why I say I feel like I've been a part of this, I started my work, I'm going to go all the way back. In college, I studied economics as well as accounting and some other things that led me to become a certified public accountant, what in some places they call a chartered accountant. And in college, the area that I wrote about that was the most interesting to me was the notion of how do you quantify the value of non-financial attributes. So back at that time, one of the premier paper that I wrote in college was about the newspaper industry. We were seeing consolidation at that time, where hometown papers were being bought up into regional papers at the cost of losing the local news. And I asked myself, what's the cost of losing local representation in the newspaper world? How would you value that? Well, of course, that was pre-internet, that was pre-Facebook, pre-Nextdoor, pre all of the marketplaces that you can create, all of the news places that exist. But the question of how do you measure a non-financial attribute has always lingered and been a part of my work. Today, its expression is, how do you measure the value of improved health outcomes? If you can cure someone versus sustain someone by having the meds for the rest of their life, and you are a provider or a pharmacology company, which one of those is financially the better deal? Well, I'd rather not cure you unless I got paid a whole lot of money. I'd rather have you pay me every month to take care of you and keep you fine. So the financial side in terms of a transactional view places the value on something other than than curing you. So how do you measure that value? And the whole notion of valuing non-financial attributes is still in the news. People like Joe Stiglitz wrote a great book a couple, 3 years ago on the subject in government settings. So it's still a current topic, and it's still something that I find myself working on, or that fits into my work every day, just as it is here. But in 2004, President Bush the Younger, among other things, he created the Office of the National Coordinator down here on the left, the ONC, under the Department of Health and Human Services. And it was really quite a prescient idea that he would say, the first thing I'm going to do is make an office that is responsible for the advancement of technology in healthcare. Big stuff. He also, in 2004, said by 2014, I would like everybody in the nation to have an individual electronic health record. Now, at that point, I don't think he thought through the idea of fragmented records, that rather, I think his vision was a consolidated single record that anyone could access. But I don't know how well he stated it. Still, it was a terribly forward-thinking idea that President Bush the Younger should be recognized for. By 2008, the election of President Obama, we also had Congress passing something with all these letters on it down here, MHPAEA, the Mental Health Parity and Equity Act. The intention was to say we should elevate mental health to the same level of service in terms of access to care, in terms of coverage, that we give to physical health-related items. Now, you'll see when we come back to this question of mental health, a constant theme is, even though we'll talk about several legislative steps in that direction, it's been really hard to achieve that, the notion that is reflected by mental health parity and equity. CHEMS 2009, we had ARRA, and HITECH. HITECH was simply the first rule that said, thou shalt have electronic health records. In order to get paid by the federal government, you have to have records and do certain things with them. The Affordable Care Act, as I think most of us know, extended coverage for people by granting access to people who otherwise have pre-existing conditions, and providing financial incentives for those who could not afford health insurance, thereby dropping from about 50 million people uninsured to about 24 million people uninsured. So right there, we had about 26 million people coming online, getting insurance and access to the healthcare system. But in order to participate, the Affordable Care Act extended and reinforced HITECH and said, you've got to play nice, you've got to use the technology, and you've got to meet some requirements. In a moment, I'll talk about the evolution of those requirements in this period, because it's really important to understand just how we have progressed. Then came 2014, the Excellence in Mental Health Act. I want to say it's the next step following the Mental Health Parity and Equity Act. That is important, but hasn't really accomplished certainly what I thought it would at that time. So I'm going to say it's there. So what? Then we have MACRA, the Medicare and CHIP Reauthorization Act. CHIP is the Children's Health Information Program. So this is extending Medicare, Medicaid, and CHIP and restructuring them a bit to again emphasize and reinforce what's in the Affordable Care Act to say if you're receiving Medicare, Medicaid, or CHIP funding for your patients, you have to meet these technology requirements. All of which takes us to 2016. And again, I was writing this, probably was late 2016 when I wrote this, because the next big change happened on December 13th of 2016. So let's assume that this represents the world just before December 13th of 2016. And at that time I said, I think we're on the stage for a transition such that in 10 years, by 2026, we will advance to something called the Learning Health System, which was really just coming out around 2010, but growing and really starting to catch on by 2016. The Learning Health System is really important. It's one of the 2 or 3 areas that I am most interested in, and today spend most of my time and most of my work thinking about and trying to advance. The Learning Health System, in essence, is a way of doing in healthcare what happens in the rest of our lives. In the rest of our lives, our activity online, our activity with Amazon, or looking up a technology or looking up something leads to what? It leads to them capturing information all about us, and then they can learn about us. And that may be a terrible thing. But for my purpose, I'm saying, why can't we do a better job of capturing health-related information? Why can't we integrate information even amongst our providers? So the Learning Health System says, rather than base your evidence-based practice on discrete studies that exist kind of in a vacuum, why aren't we extracting data from what's really happening every day and translating that into evidence-based practice? That's the notion of a learning health system, to constantly learn and refine across a population or within an organization. And so we'll come back to how far we are from it. I think we've made a lot of progress, but we are not there. I would redo this, and I'm not sure what year I'd put there now to have a mature learning health system, but we'll talk about that. So one of the key things that came out of high tech and reinforced in the Affordable Care Act was the idea of meaningful use. And I want to include this because it tells you what the expectations were for the use of technology in some key years. In stage 1 was 2011 and 2012. Now, these are the consumer-facing things, by the way. This isn't the whole notion of electronic health records. In 2011 and 12, meaningful use stage 1 requirements said, first, you have to capture the data in your electronic record, and you have to share it, which might mean simply printing off a piece of paper and say, here's your medical information. Ta-da! We've now met the standard for interoperability. And we'll talk about exactly what information in just a second. Stage 2 began in 2014. And while it says advanced processes and HIE, it was really beginning to move from a pretty static kind of a report, whether it's an electronic report or a paper report, it's a static set of information, to get at the notion of health information exchange. That this hospital should exchange with that provider, that should exchange with that lab system. All of it should happen electronically. It wasn't until 2016, 8 years ago, that we had announced something called Meaningful Use Stage 3, which said we're going to look at the outcomes. What are you doing with this information? The first 2 just said, show us that you can exchange the information, you're good, we'll give you the bonus points. It wasn't until 2016 that the government, in paying people, said, now let's show us that you're doing something that has an effect on outcomes, beginning to look at things like 30-day readmittance rates. Are you outside the normal boundaries of what we expect for 30-day readmittance rates? This is all beginning to move towards a shift that we'll certainly talk about a lot, that most of you should be familiar with, from fee for service to value-based care. Fee for service meaning the more services you deliver, whether it's your fault or not, you get paid for every service you deliver. You are not accountable for outcomes. Value-based care, in one way or another, says, yeah, we're not going to pay you if we if your delivery of that service that we paid you for shouldn't have this patient coming right back in the door with a complication in 30 days. Now, it's not absolute because not everything can be controlled, but it's that trend of accountability. It's called risk-based payment sharing that begins to come in. So this was the first stage that was really pretty important through 2016. Another comment on that first item that I said in stage one, you had to have a document called the continuity of care document, whether it was electronic or paper. It was simply a list of these items. That's it. Demographics, patient history, medications. There's the entire profile. Hopefully my doctors have a lot more than just these things. Now, these look like on the face of it, the right kinds of categories to include: problem lists, diagnoses. But do they include the level of detail that's necessary in order to treat someone? I don't think so. That was followed with something by the Consolidated Clinical Document Architecture, which is a big deal. And I'm going to go through these quickly because this is more lingering on these details is more important for my students than it might be in this discussion. But the idea is this was an architecture as opposed to stipulating certain types. So it was specifying a standard for machine readable information, not only for that CCD, the continuity of care document, but for other documents as well. In fact, the CDA did not specify any content, and it's been adopted, therefore, as a standard in a way. You'll see how that's evolving. It's really, the CDA is also specified as a requirement to get to certain meaningful use, to get to certain levels for funding purposes, for getting compensation. You have to meet these standards. None of this relates to consumer health informatics. This is all basic stuff to say you have to be able to exchange with each other. The consumer hasn't even entered the picture yet. So if you follow the money, meaning there are several payment models that drew upon how you're doing, something called the Merit-Based Incentive Payment System, MIPS. Even if you aren't adopting a value-based care model like you're going to see in a moment, we're going to, now speaking in terms of the federal government funding agencies, Medicare in particular, we're going to increase your, by a multiplier, what we pay you, or decrease it based on how well you are doing on, among other things, this technology adoption. Again, nowhere is there at this time was there a stipulation to do anything for the consumer other than give him that continuity of care document, either as a file or most commonly a printed paper. Here's the summary of your stuff. There you are, go. That met the obligation. Alternative payment models are beginning to move towards value-based care. It was an intention to say for those organizations that represent government organizations, so Medicare Advantage plans for Medicare, Part C as they're called, Medicaid managed care organizations might have an insurer representing them. Those plans could stipulate the extent to which you complied with and add to, they had to meet the minimum standards, but could also add requirements for electronic health information technology. Meaningful use evolved to become something called the interoperability program, which still operates today and has the same kinds of criteria about your ability to be interoperable and create, as we'll see down the road, something called a National Health Information Network that is not in, it's in place, but it's not fully developed yet, implemented yet. That means that anytime you go in to see a doctor, they should have all your information. And anytime a consumer health application accesses your information, it should be able to access all of it. But that's the future. We're not there yet. And so an early example was simply a patient portal. You'll get a reward if you offer a patient portal. Now, what does that patient portal do? It meets, I think, the lowest threshold of consumer health informatics. And again, we'll talk about all the forms in the next week. But it was a low standard and one of the early notions that we had. And here's my note for myself. This was October of 2019, and my note about it is that I was wrong. For the benefit of 2020 hindsight, It is easy to see that whatever incentive may have been intended, the larger history of pointless and ever-changing regulations and requirements, combined with a yo-yo-like revenue strategy, mostly associated with who's in power in the White House, has led providers to do the least they can to meet evolving requirements, unless it's absolutely certain that the guidance has permanent, clear, and significant value. And frankly, that's a reasonable strategy. And it summarizes why I think healthcare IT, but particularly consumer health IT, has languished compared to any other form of consumer engagement through technology. All right, that's that on lesson 2. Next up, lesson 3, we're going to go a little bit more into the Cures Act. We're going to go into, not a little more, we're going to start on the Cures Act of 2016.